I think we are live. Hi, everyone. Welcome. We're so glad to be hosting this talk today. I'm Jen Schonger from the New Jersey Autism Center of Excellence, which is funded in part by the New Jersey Governor's Council for the Medical Research and Treatments of Autism and by the New Jersey Department of Health. I'm here today with Dr. Clarissa Kripke. Dr. Kripke is the clinical professor of family and community medicine. She cares for people of all ages and has special interest in primary care of transition age youth and adults with developmental disabilities. She directs the Office of Developmental Primary Care, a program dedicated to improving outcomes for people with developmental disabilities across the lifespan, with an emphasis on adolescents and adults. Welcome, Dr. Kripke.
Thank you so much. I'm delighted to be here with you today, and I'll share my screen now.
Okay, perfect.
Let's see.
Just a few housekeeping notes to add in is that Dr. Kripke will be sharing her presentation. We do hope that people will ask questions. If you would like to ask a question, you would have to be logged into your YouTube account so that you can add your comments in the chat. The session will be available to watch at any time and can be found on our New Jersey Autism Center of Excellence YouTube page. And I'm going to go off screen so that Dr. Kripke can present, and then I'll be back on for the Q&A at the end. Thank you so much, Dr. Kripke.
Thank you so much. Can you see my screen? Okay.
Yeah.
There's a problem. Oh, now. There we go. So I have nothing to disclose. I have no commercial interests. I want to thank the Stupski and With Foundations for their support of my work. I'd like to give everyone a big group hug today, regardless of who you are. If you experience meltdowns, or if you're a parent or a professional who's trying to support someone through meltdowns, this is hard for everybody. We need to treat each other very gently. These are particularly trying times. We're all impacted by the pandemic, by climate floods and heat and cold and global warming fires. And we're worried about the health of the things that stabilize us, like our schools, jobs, housing, and our access to food. Most of us don't have our usual family, community, medical, and professional supports. We aren't getting the exercise we need. Our politics and futures are uncertain and feel unstable. This is a recipe for major stress, and stress can get directed outward or inward and take the form of aggression or self-injury. This talk is not about intentional harm or premeditated, planned criminal behavior. If you are in a domestic violence situation, if you're being abused, if you're being neglected or mistreated in any way, please find a way to let other people know so that we can help you get safe. If you're aware of someone who's being mistreated, please report it. People who are in crisis themselves are not going to be able to help others effectively. Take care of yourself first. Crises bring out both the best and the worst in people. As Mr. Rogers wisely said, look for the helpers. Please ask for help and accept it. Also, if you're overwhelmed and may need help managing a behavioral or a psychiatric crisis, please develop a plan now for what you're going to do. Police are not equipped to safely handle these situations. Work with your local developmental services, community agencies, and healthcare providers to find or develop resources to de-escalate situations and transfer people into safe care if needed. Finally, I want to try to limit my comments so that we'll have a lot of time for general discussion. Please remember that this is a public forum and it's being recorded. All people deserve privacy, especially when we're discussing these very sensitive issues. You can contact me privately afterwards, and we can make my email available to you, but please do not refer to family members or to clients or tell stories about them in ways that could identify them. None of us is defined by our worst moments. I will ask the moderators to help me cut people off if they start to share confidential information or medical information or stories that have names or details which could breach their confidentiality. So today I'm going to talk about aggression and self-injury in people with developmental disabilities. Before treating a behavior, it's critical to ask why and understand why it is happening. Communication is key to successfully understanding a behavior. All people communicate. Some behavior is communication, but sometimes behavior is not purposeful or intended. It may be just a reactive fight or flight situation. It might be impulsive or repetitive. People can get frozen or stuck due to brain difficulties with coordinating their sensory information and their motor movement. It's also important to recognize that communication is a two-way street. We can say that you can't just say that a person doesn't communicate. Communicate is a relationship between two people or more. Both people have a really important role. The person who's trying to get something across and the person who's trying to receive the message. If the communication is breaking down, it's not just a function of one person, it's a function of a relationship between two people. Aggression and self-injury may be a sign of communicating that they're having a medical problem. It also may be a sign of demands exceeding someone's capacity to manage them, a poorly adapted environment, an unmet need. It could be miscommunication or misunderstanding, or it could be a psychiatric problem. For people who have cognitive and communication differences, illness frequently presents as a change in behavior or function instead of a patient complaining of a sign or symptom. Illness frequently presents as a change in behavior or function. For example, a broken bone is not usually a hard diagnosis to make. A person comes in and says, I fell, I think I broke my ankle. The doctor does an x-ray, and sure enough, you broke your ankle. But in situations where people are unable to effectively communicate the cause of their distress, it's amazing how easy it is to miss something even as big and obvious as a broken bone. If it's hard to notice a broken bone, imagine how easy it is to miss something like a headache or heartburn. Whenever there's a change in behavior or function, it's important to think that it could be a medical problem. If you don't have the correct understanding of the cause, you're not going to come up with the right solution. I'm going to spend the rest of this talk going through an organized way of thinking through possible causes. Challenging behavior. Dear, you are a diamond in my heart, but right now you are annoying me. Challenging behavior is not a patient complaint. Nobody has ever come to me and said, Doctor, I have challenging behavior. Can you please help me? They might say I'm anxious. They might say I'm in pain. They might say I'm being mistreated, but no one says I have challenging behavior. Challenging behavior is a caregiver complaint, a complaint of someone who's supporting someone else. When anyone comes in with a complaint of challenging behavior, my first question is who is being challenged and why? The same behavior may be a problem for one person, but not for another. It may not be the behavior that's changed, but a change in the caregiver's ability to cope. For example, if someone is extremely active, it might have been okay when their caregiver was in good shape, but not okay when their caregiver starts to have back problems or has an injury and can't keep up anymore. The solution isn't to make the person who's being supported move less, but to figure out a practical solution for the caregiver's change in physical ability to support and possibly relieve them of some of their caregiver responsibilities. Has there been a change in the caregiver's ability to cope? Do they have new competing responsibilities such as work or care for a sick or disabled parent? Right now, with caregivers stretched to the max, this is frequently the problem. As a doctor at this time, I don't recommend that people with disabilities return to indoor group activities for congregate day or vocational services anytime soon. However, if you feel overwhelmed by your responsibilities, or if you are the sole caregiver of someone who needs significant care and support, it's really important to share that responsibility with others. Having an aide come into your home with precautions or take you out into the community to enjoy activities does pose some risk of COVID-19, but it's a manageable one and it's safer than going without the help you need or relying on an overwhelmed or unsupported caregiver. People with disabilities have the right to maximize their potential, and we should be working on that, but so do caregivers. If people are feeling like their caregiver responsibilities are interfering with their ability to pursue their own dreams and get their own needs met, that's a problem that also needs to be solved. They need to be better supported. You need to be better supported. One example is respite. Evidence shows that we can actually reduce hospitalizations of autistic people by increasing funding for respite hours. Usually, when we think about doing interventions to make people healthier and keep them out of the hospital, we're not usually thinking about supporting caregivers, but that's often the best solution. Caregivers need training, they need social support. The evidence is that caregiver well being has very little to do with the support needs of the people they support. It has more to do with the social support that they receive, the attitudes they take towards their job as a caregiver, and the services and supports they can access. Sometimes additional adaptive equipment, such as augmentative communication equipment, Hoyer lifts, or home modifications, can make a huge difference. I want to talk a little bit about meltdowns versus tantrums and the difference between them. I want to talk about this difference because the solutions are different depending on what's going on. Meltdowns are kind of like the blue screen of death on your computer. It's as if your brain is overloaded, so it's going to shut down temporarily. If someone's having a meltdown, they're overwhelmed. It's a reactive mechanism to being overwhelmed. It can be triggered by sensory things, by being tired, by too many changes or social pressures or something else that's going on in their life. It continues even if the person doesn't get any attention. Safety may be compromised during the meltdown. They may not be able to protect themselves from hitting things, hitting themselves, bashing things. Meltdowns aren't goal oriented. It's not a way to get someone else to do something. The person may need help regaining their control. A tantrum is a completely different thing. It's more want directed. It's about trying to control someone else's behavior. For example, I want the gum out of your purse and I'm going to sit here and cry and kick until I get the gum out of your purse. People having tantrums check in to see if their behavior is working. If they get ignored, they might escalate or they might give up. During a tantrum, protective mechanisms are intact. Like they're not likely to hurt themselves by flailing around or hurt other people by bashing into things or bashing into people. During a tantrum, um, you're in control. You're trying to manipulate someone else. If the goal is accomplished, the tantrum will stop. If it works, it also means that you may use that strategy to get what you want again. So be careful about tantrums being an effective way to get your needs met. It's important to know whether the behavior you're observing or trying to support someone through is a meltdown or a tantrum, because the strategies will be different. In a meltdown, there's no goal. The person can't process at that time. Reasoning with them or lectures aren't going to work. In a tantrum, reasoning or bargaining might work, but that's not going to work in a meltdown. Behavioral methods help manage tantrums, but they may further stress and traumatize people who are having meltdowns. The old outdated model is to think about challenging behavior as a problem with the person who's having the behavior. They're a bad person because they're having this behavior, they're sick or having some disability related problem. The old solution was to try to control the person who's having the problem, to restrain them either with medicines or physically. If that couldn't be done, the solution was to remove them from society or to seclude them in an isolation room or an institution or somewhere else. In the past, people even resorted to medical procedures like surgery on the brain to get people to stop the behavior. That's the old model, and we know better now. A newer model is to change people's life circumstances for the better. We can't manage behavior in the context of unacceptable lifestyles. If someone's situation, their social environment, the activities they're doing, the people they're with, or their physical environment is unacceptable to them, then the problem that we need to fix is to make their environment and their circumstances acceptable. For example, if they can't be in a room because the air conditioner is too loud and causing them such discomfort that they feel like they're going to melt down, the solution isn't to punish them, to yell at them, or tell them they need to be strapped to a chair so they stop the behavior. The solution is to turn off the air conditioner, or if that's not possible, to move to a different environment. The problem that's causing the behavior is not always obvious. Often it isn't anybody's fault. Usually, I would say it isn't anybody's fault. Trauma-informed practices means that when someone's having a problem, we don't ask, "What's wrong with you?" We ask, "What's happened to you?" It's about being empathetic and assuming that there's a reason for the problem. We need to focus on skill development, caregiver skill development, as well as skill development for the person who's stressed. This might mean learning a new communication technique, learning better ways to get your needs met, or learning strategies for self-calming or how to help someone else calm themselves down. It's about practicing mindfulness, skill development, knowledge, full and active inclusion. It's about giving people opportunities to do the things that they want to do and that other people have the opportunities to do. Overall, it means improving their quality of life. By saying this, I'm not trying to diminish how challenging some of these situations can be, how stressful, or even how dangerous. But escalating these situations through harsh language, reacting emotionally, restraining, or using other old methodologies only makes things worse. In general, and keeping in mind that every situation is unique, we want to de-escalate these situations to bring it down. We're not going to eliminate meltdowns, and most of us, if we're honest with ourselves, whether we have disabilities or not, have meltdowns on occasion. It's more a matter of how do we reduce the frequency, the intensity, and what they look like. Meltdowns often happen because of physical complaints or because of illnesses that are undertreated or which haven't been diagnosed. How many of us have gotten unreasonable when we don't feel well? I know I have. A third of people with developmental disabilities have vision, hearing, or sensory integration problems. Most have multiple chronic medical problems. About 20% have seizure disorders, and about a third have a diagnosable psychiatric disability. When people have meltdowns, medical problems are contributing or causing the problem most of the time. If you're supporting someone who has challenging behaviors or meltdowns and you just made a wild guess that it had something to do with their health, you would be right 75% of the time. You should always think about medical causes first. Think about them before you think about other reasons for the behaviors. When I talk about the frequency of medical conditions causing behaviors, I'm taking that from a study of people who got as far as consulting a specialty psychiatric service. For someone to get referred to a developmental psychiatrist for formal evaluation means they typically tried quite a few things before they got to that point. Most of those people had already talked to their primary care doctors and had already had quite a bit of evaluation. But even in that population, 75% of the people who are experiencing problem behaviors had an undiagnosed or undertreated medical condition, and a significant amount of the time when that was addressed, the behaviors completely stopped. The medical causes are not easy to diagnose or detect. While challenging behaviors are extremely common, they don't tend to last forever. Meltdowns last an hour or two. The more dramatic ones tend to be shorter. It doesn't feel like a short time when you're going through it, but people get tired. Also, when you're with someone who's going through a difficult period like puberty or a change in their routine, or when they're developing a medical problem, it can feel like the meltdowns and challenges will never end. Whenever you're in the middle of it, head banging, chewing on skin that's causing infections, having episodes in public places, time moves so slowly. There's a lot of fear and emotion that get associated. But it's important to remind yourself that it doesn't last forever. Even if you do nothing, even if you never figure out why it's happening, the data shows that most challenging behavior tends to get better with time. Managing a behavior crisis. This is the SCARED method. I got this acronym and strategy from Deborah Lipsky, who is an autistic first responder. Her book is called Managing Meltdowns, and I highly recommend it for anyone who is working with people who have behavioral crises of various sorts. She describes what meltdowns are like from the inside and gives a very easy to read and clear explanation of what to do. The SCARED method is to do the opposite of what most of us feel like doing. Most people's impulses, including my own, are to get upset, to lecture, to yell, to feel embarrassed, or to try to control the situation. When I see someone who's upset, who is at risk of hurting others or at risk of hurting themselves, someone getting themselves in trouble or getting me in trouble, my own anxiety levels increase and I get worked up myself. This is not helpful. It's really important to take care of yourself so that when this situation comes up, you can go to your calm place. If you have those impulses, like I do, try to control them. Keep the lid on them. Let's go through the acronym. SAFE. If you're not in a safe place when the meltdown happens, then it's important to get into a safe place. If you're supporting someone who's flailing in a way that someone nearby could get hit, or if there are objects nearby that could be thrown, if you're on stairs or near a ledge, don't focus on trying to control the person. Instead, focus on getting people and objects out of the way and getting the person into a safe place. If the person is in the middle of the street, get them to the sidewalk. If it's happening in the classroom, either help them leave the classroom or help other people leave. Keep a safe distance away. Sometimes using furniture can help with that. You can, if you put furniture in a way where you can go 360 degrees around it, then if they go one way, you can go the other way, and you have a barrier between you and the person if you need to stay safe. C is for calm. Simple, clear instructions, not lectures. This is not the time to talk about feelings. Keep it to simple words such as Jane, stop, or Jane, here. Affirmations, positive words. Use positive, calming words. Routine. If you know the person has safe routines, then try getting them into one of their safe routine activities or patterns to work through it. Empathy. The person who's having a meltdown is not the enemy. Your approach should be trauma informed. What happened to you, not what's wrong with you. Develop an intervention plan. This is not something you can do in the moment, but hopefully you're not entering these situations without a plan in place. If you don't have one, then as soon as the episode is over, it's a good time to start developing a plan for what to do next time. Here is a sample meltdown plan. This plan was written by an autistic, nonverbal person who uses augmentative communication. Respect me when I have a meltdown. I have meltdowns periodically. Don't overreact. I'll pull myself together faster if you have patience in the moment, if you have hard words. It's not nice to make me feel bad about it. Only touch me if I've said you're someone who can. Respect my space in the moment. I have trauma from being underestimated, so I melt down often because of my trauma, and it's not your fault. When trying to figure out why meltdowns happen, think about what precipitated it, what came right before. How can we in the future reduce the frequency? If that's not possible, how can we reduce the meltdown's intensity or length? Also think about the conditions that have reduced the person's capacity to cope. Things like fatigue and hunger, too much sensory stimulation, too many people, or too many demands. So what's the first step to sorting out a change in behavior or function? 1, collect and review baseline data. 2, interview caregivers. 3, do an observation. 4, do a physical exam. Or 5, ask the person. What's the first step? This is a quiz. You can put your answers in the chat. I can't see the chat. Are people responding, Jen?
Not yet.
Okay, I'll move on. Think in your heads what your answer would be. If you can't come up with the technical to answer in the chat, that's fine. Okay, so all of these strategies are important, but I always start by asking the patient, even if they're nonverbal, even if they don't have a formal communication system, even if I'm not sure whether I'm going to get a meaningful response. When I try, when I give the people the opportunity, when I support them, I'm amazed at how much useful information I get in return. Back to what I said before at the beginning, communication is a two-way street. And if you're actively listening, actively trying to listen, you're going to get more out than if you don't take those steps. Here's a story. I had a patient who was brought in by her sister, and her sister didn't know her very well because she'd been living with her mother, and her mother had just passed away. She thought something was wrong, but she really didn't know what. I didn't know the patient at all. The sister was insisting that the patient was nonverbal and couldn't provide me with any history, but I said, let's try. We have no idea what's going on here. It can't hurt to try. So I just started trying things. I sat her down in front of my computer to see if she could type. She did poke on letters, but she didn't type anything that I could interpret. I got out a picture book of anatomy and bodies to see if she might point to something or if one of the pictures might get a reaction. I gave her choices like, show me how you say yes, and then watched her very carefully to see if she made any kind of gesture, eye movement, or sound. I said, show me how you say no, to see if she would make any kind of consistent gesture or sound. That didn't work. Then I said, touch hurt. She took my hand, she put it on the right upper part of her stomach. Based solely on that communication, I ordered a sonogram, and it turned out she had gallstones. That's a really hard diagnosis to make if somebody doesn't give you a hint about where they're having pain. There's nothing else that shows up in a person who has gallstones that might indicate what the problem is. I wouldn't have been able to make that diagnosis until she was sick enough to be in the hospital. The only way that I made that diagnosis is because of the information that she provided. Trying this kind of strategy doesn't always yield useful results, but it does often enough that it's always worth trying. It also sets the person up thinking, they're trying to work with me on this. I think I'll try a little harder to communicate with them. A lot of the communication problems are learned helplessness. It's not that people can't communicate, it's that they're used to people not listening to their communication signals or not paying attention to them, and so they stop trying. And just because you've tried these strategies before doesn't mean you shouldn't try them again, because sometimes it takes people a while and developing that relationship before they start producing useful communication strategies. They may have to experiment, just like I was experimenting and I was experimenting on how to listen, and they were experimenting on how to send a communication signal. All of us shut down if we think people aren't listening to us and we don't try to get our communication across. A lot of times people can communicate better than you think they can, but don't try because they don't think people are listening. Giving people the impression that you're listening to their verbal and nonverbal cues will increase how hard they try. Here's another story about why we need to presume that there are reasons for behaviors and systematically search for those reasons. A person was going around doing really challenging things, like going up to law enforcement and grabbing them, laying down in front of cars, a whole variety of things that are quite alarming and dangerous. He was losing his housing because his caregivers didn't feel that they could keep him safe. He'd also seen multiple doctors. Finally, a primary care doctor did a really careful physical exam from head to toe, and they found this like little toy bead in his ear and removed it, and the behaviors completely stopped. Imagine, like this man, having even a very simple condition, maybe a yeast infection, an itch you can't scratch, conjunctivitis, like, red eye or constipation. Imagine you can't tell anybody about it or help yourself. Sometimes people try to get your attention by doing things that can appear to be aggressive, but they're really saying, I have a problem and I need help. That's why this patient was going to authority figures and trying to get their attention. It looked aggressive, but he was actually asking for help. Here's another story. A patient was going up to people and punching them in the chest. That was viewed as scary and aggressive. It turned out he was having heart pain. He was trying to tell people that he needed help with a medical problem. If we'd simply given him medication to calm him down, we would have completely missed the point and also missed a major medical problem. Another situation. A patient started throwing chairs at caregivers. She was having increasingly severe meltdowns. It turned out she was being hit by a caregiver. The caregiver was someone who was very well intentioned. The patient had behaviors she feared were going to get her into trouble and was handling it in the way it had been handled in her childhood, which was with tough love. She was disciplining her by saying firmly, "You're not doing that," and giving her a slap. She wasn't trying to hurt the person, but was trying to manage things in the way she knew how. Nevertheless, the person was being abused, and that's where the behavior was coming from. When the staff person was fired, the behavior stopped. Here's another question to ponder. A person with no language communication skills who doesn't speak or type or use sign language keeps hitting herself on the side of her head. The caregivers are concerned that this could cause an injury. What should you do? You could, one, punish her with something mildly aversive, like some static noise, whenever you see the behavior. Two, you could explain why head hitting is a bad idea and say no or stop when they're doing it. Three, you could ignore the behavior and hope it goes away. Four, praise or reward the person when they have longer periods of time without hitting themselves. 5, hold the person's hands down gently every time they try to hit their head until they stop trying. 6, give themselves something else to do with their hands, like giving them a favorite object every time they start hitting their head. Or 7, presume that there's a reason, and when they're calm, ask and systematically search for the trigger. What do you think? One through 6 here are primarily old school thinking. When someone's having an alarming behavior, if you don't know why, and if they're at risk of hurting themselves or other people, 90% of the time, the primary focus is on getting that behavior to stop. People are eager to do what it takes because otherwise they worry something bad will happen. I don't want to minimize people's stress and fear because the consequences of these behaviors can be really significant, but it's important to take your time to figure out why it's happening. Let me tell you a story. I know someone who wouldn't stop chewing on his thumb. Eventually, the thumb was so damaged it got gangrene and fell off. That's a really significant behavior. So after trying everything else they could think of, his doctors decided to try physical restraint. They built a brace that would allow him movement, but not allow him to get his hand into his mouth. He ended up breaking his own arm in the effort to get his thumb into his mouth. Another story. In the middle of a meltdown, a patient was banging his head against a wall. His caregivers were alarmed that he might get a head injury, so they put their hand between his head and the wall. What do we do in the middle of a meltdown? Back off, stay calm, remove things that can be dangerous. It might have been okay to come up from the side and slide some sort of pad between his head and the wall. But what they did was they put their body between the person who was out of control and something that was hard. And that was not good. The patient ended up biting the caregiver. Another staff person tried to help the caregiver because he was getting bit. He tried to physically restrain the patient by holding his arm back, and the patient's arm snapped and was broken. He ended up in the hospital. There were complications, and now he has a permanent physical disability. I'm telling these stories because I'm not trying to underestimate the significance of these behaviors, but restraint, punishment, focusing on the behavior instead of what's causing it simply doesn't work. It gets people hurt, both the people who are struggling and those who are trying to help. We need to get through these episodes safely and then focus on why it happens. If we don't understand why the behaviors happen, we're less likely to be successful in stopping them, and we'll end up mismanaging them. So how do you think systematically about a patient's possible medical needs? I use a mnemonic HURTS, H-U-R-T-S. It doesn't include everything that could possibly be wrong medically, but if you work through it, more often than not, it will give you a hint that will lead to an answer. I find that working through this mnemonic just gets people into the mode of trying to think about why instead of focusing on how do we stop the behavior, what pill, give me when people come to me with challenging behaviors, their impulse is to say, there must be a pill, there must be an easy answer, you need to get the behavior to stop. I don't care about why, just get the behavior to stop. And it takes a lot of art of medicine to get people focused on thinking about why, because you're not going to be able to treat it effectively, and you're going to end up doing things that are more harmful than helpful if you don't understand the why. So here's one of the strategies, is to go through this mnemonic. Head. Migraines are a very difficult diagnosis to make if someone can't tell you that they have a headache. Hearing or vision changes can also trigger some changes in behavior, and caregivers are really bad at recognizing vision and hearing problems in other people. People can be totally blind or deaf, and caregivers may not even notice. They especially may have difficulty noticing if the person has significant motor challenges. Dental problems are super common, and caregivers and doctors often don't think about it. Consider the last time you had a toothache or a gum problem and how painful that was. Other unrecognized injuries to the head are also possible. Urinary tract. You can have infections, you can have kidney stones, you can have obstructions, so that people can't pee and their bladder fills up. Reflux or heartburn is really uncomfortable. It can present as insomnia or difficulty with sleep. There can be other gastrointestinal complications such as constipation. Thyroid problems or traumas such as broken bones or orthopedic injuries or sprains. I've had patients whose injuries have presented in the form of the patient slapped me when the caregiver is trying to help them, was trying to help them up or move them. They were actually grabbing a broken arm and they were defending themselves by slapping them away. Uh, People can behave very violently when they're being injured, even if the injury is unintentional. Seizures. Seizures can present in very unusual ways. Not all of them present as the typical all over body shaking. Any behavior pattern that lasts less than 3 minutes and looks the same at each time could be a seizure. This could present as flailing that looks aggressive. It could be emotional lability. That means like somebody just starts to laugh or cry completely out of context, very suddenly or inappropriately. That could actually be a type of a seizure type. Other kinds of seizures might make people unable to move or sort of blank out. Absence seizures. Also, under S here, side effects of medications are extremely common and often go unrecognized. Let me tell you a story about using this mnemonic. A patient had such bad insomnia that their parents were at their wits' end and were considering an out of home placement. But the insomnia was not characteristic for this person. Most of their life, they'd slept just fine. So I started thinking about why this person might not be sleeping. We started working through the Hertz mnemonic. I got to reflux and I thought, when people lie down, it usually makes their heartburn worse. Why don't we just try some over the counter heartburn medicine and see what happens? 2 days later, the symptoms that had been going on for months were gone, and the family was no longer thinking about out of home placement. It didn't solve all this person's problems, but again, even simple medical problems can become big problems if you can't get the help you need. Of course, medical problems aren't the only things that can cause challenging behavior or change in behavior. Behaviors can also signal abuse, even unintentional or well meaning. Um, uh, uh, can be experienced as abusive by the person. It could be escape or avoidance of demands. This can be mistaken for tantrums. Let me give you an example. A sound or light in this room is bothering me. So if I'm disruptive, then I know I'm going to get removed from this room, which is what I need. So I'm going to be disruptive. It could be increase in arousal or self-stimulation. Some people have sensory issues where they don't really feel their bodies or feel where their bodies are in space. So hitting or tapping themselves can help them feel where their body is in space. So they're not trying to injure themselves, even though it may look like they're hitting themselves and that may look painful. It might be a means of accessing preferred activities or objects. It could be a need for social attention. It could be a sign of a psychiatric disability. A lot of times we don't understand why someone's doing something. It can look like it came out of nowhere, and we can be confused. Uh, um, we can think something is a hallucination or it can seem completely irrational. Not understanding why somebody is doing something is not the same as there not being a reason. It could be something that's sort of outside of our experience, like somebody could have synesthesia. So, for synesthesia means sort of sensory scrambles in the brain. So, somebody might experience an emotion when they see a certain color. So they see somebody come up to them who's wearing a certain color, and that's a negative emotion for them based on the color, and they're reacting to that, and that can seem to be coming out of nowhere, seem like a hallucination. Um, uh, Sometimes people have colors associated with music or other kinds of different sensory experiences of the world, and that can be very hard to diagnose. Or they may be able to hear extremely well, much better than typical people, and maybe hearing things that other people don't hear, but they're actually hearing it. It's not all in their head. Um, so they could be overhearing a conversation that's happening across a room that other people don't hear, but that's distressing to them. Or they could be hearing a mechanical sound that's bothering them. Uh, People can also have psychiatric disabilities like bipolar disorder, schizophrenia, anxiety, or depression. Psychiatric disabilities are treatable with psychiatric medication and therapies. Psychosocial stressors, like being stressed out because of social relationship issues or because you're trying to pursue power and control. Challenging behaviors can be a way to reduce arousal or anxiety. Sometimes people find, pinching themselves can distract from a different kind of pain or an emotional pain. It could be a way to manage sensory sensitivities, or it could be substance abuse. Let me tell you some stories. A patient of mine was living in a group home that had recently had a budget cut, so they weren't doing as many activities. My patient figured out that if she threw things, she would get her preferred staff member to work with her, and she would get to do what she wanted to do. She was able to establish power and control by throwing things. Sometimes a functional behavior analysis can be useful. That's taking data on what happened right before the behavior and what happened right after, and that might help you start to think about what's going on. You might start to see some patterns there. You can take data on what changed in their life, their activity level, their ability to communicate, behavior, diet, mood, etc. One caveat to functional behavior analysis: I used to teach that all behavior was communication, and I'm trying to undo that teaching now as I've learned from autistic people that all behavior is not necessarily communication. It can be a problem with impulsivity or motor control, and also sometimes people might be doing something because they have an obsessive compulsive need to do it. They know it's wrong, but they can't stop themselves. They may not have the body control to meet the expectation. I know you want me to go over there. I'm trying to get over there, but I can't get my body to initiate the movement. And it looks like I'm being defiant, but I'm really not being defiant. When you're trying to figure out where a behavior is coming from, look for clues in what's changed. Has their ability to communicate changed, their activity level, their behavior, confusion or orientation, their diet, their mood, their movements, their sensitivity to sound or sight or touch? Have their skills changed, their strength, their steadiness, their energy, their skin, their sleep, their stool or urine, their vital signs? Look for what changed, and that may give you a hint about where to look about what might be going on. I can Interpreting pain is also sometimes challenging. Sometimes I'll ask a caregiver, "Do you believe this person is in pain?" And they'll say, "No, I don't think so." And I'll say, "How do you know?" And they'll say, "Well, they aren't doing the things that we'd usually expect from someone in pain. They aren't grabbing the part that hurts or making groaning sounds, crying or grimacing." But not everybody with a disability does those things, and frankly, non-disabled people don't always either. Those behaviors are usually in response to acute pain, like stubbing a toe. But when we have chronic pain, like the back pain I've had for the past 3 years, I don't go around making those facial expressions and movements all day long. I just get cranky. Sometimes people never make those indications. Also, bear in mind that we behave differently when we're in social environments when people are watching than we do when we're alone. If I stub my toe and nobody's watching me, I might not say much. If I'm in a room with people, I might make a bigger production out of it. Maybe the person did make a facial expression, but it was quick and nobody was watching at the moment. Often people with disabilities who don't use speech to communicate are used to other people ignoring their communications, so they may not be trying very hard to communicate that they're having pain. Also, beware that some changes in behavior can make caregiving easier. Caregivers tend to bring up problems that make caregiving harder. If sometimes making if something makes a caregiver's life easier, they may not think to mention it. For example, they may not mention that a person had stopped menstruating, or that their stools are hard and only come once a week, or their activity level has decreased. But decreased activity, like sitting in front of the TV all day for a typically active person, could indicate depression, it could indicate a thyroid problem, or it could indicate some other form of illness. Because it makes the caregiver's life easier, they may interpret it as the person just being relaxed, and they may be relieved and not alarmed by it. But any change in behavior or function could indicate a medical problem and is worth working up. I'll tell you a story about that. I had a patient who had a very abnormal way of walking. And when people walk abnormally, eventually, usually they're going to get arthritis in their knees or hips or ankles. So I was asking the caregivers, do you think this person's in pain or maybe having some signs of arthritis? And they said no. And again, they said I said, how do you know? And they said, well, he doesn't have that typical pain behavior. But then when I reminded them that people don't necessarily have those, they aren't crying, they aren't grimacing, they aren't clutching the part that hurts necessarily, they said, well, taking a walk around the neighborhood was one of the most important things in his life, and now he doesn't want to take his walks anymore. I said, oh, well, that's a change. The staff wasn't alarmed by this because it was just work for them to go take him on his walk. Um, but when I said, why don't we just give him some Tylenol and see what happens? And sure enough, he started to want to take his walks again after we treated pain, and we just had to make an educated guess and give it a try. Respecting agency. When you talk about self-injurious behaviors, it's important to react to what's actually happening and not focus on our fears of what could happen. So let's talk about the difference between hurt versus injury. Injuries are bad, but we do things that hurt all the time. So injuries are things that might cause long-term consequences or be permanent, but we do things that hurt all the time. We play rugby, we pluck our hairs out of our face, we get tattoos, we engage things that aren't going to cause any serious damage, but which are uncomfortable, like going camping. If it hurts, but it isn't injurious, try to lower your anxiety level about it. You may not need to intervene at all. Hazard versus risk. I was supporting someone at a childcare area in the gym, and the child kept running out of the gym through the alarm door. There was another alarm door that went into the street. The childcare supervisor said, this child cannot be in this childcare area because they're running out the alarm door that goes into the gym, and therefore they could go out the alarm door into the street, and we're afraid they're going to go into the street and get hit by a car. That had never happened before. The kid was interested in being in the gym, not being outside. True, there was a risk that he could go out that other door, even though he never had, and even though that wasn't why he was running out the other alarm door. But it was a small enough risk that it wasn't a real hazard. The chances of the kid running out the door into the street and getting hit by a car was low and did not justify excluding him from the program. Unusual or atypical behaviors versus behaviors that violate the rights of others. So it's important to respect people's natural movements and their natural behaviors and not interfere if they're not hurting anybody. So eye contact, stims, we need to things that aren't hurting anybody but just may look unusual. Uh, Imagine if somebody told you that you had to move your body in some way that felt very unnatural to you all day long. That would be very stressful. It would tire you out. You might end up having more meltdowns. So if something is not violating the rights of others, it's not hazardous, it's not injurious, leave them alone. Um, Respect natural movements and behaviors. Also, interpret behavior neurologically and developmentally. For example, if someone's a young child and they have an imaginary friend, we don't freak out and consider that psychosis. Some adults also manage loneliness or work out problems by talking to imaginary friends. Sometimes somebody might be doing something that's completely developmentally appropriate, like asking repeatedly, when are we going to get there? Because they don't have much experience with travel or because they have a short term memory issue. That's not a behavioral or a psychiatric problem. It may just be developmentally appropriate behavior that we accept, like we accept developmentally appropriate behavior in children. Developmentally appropriate behavior needs to be tolerated and accommodated. So, decreasing behavioral disabilities is, to review, is about improving body functions and structures, increasing activities and participation, improving the social and the physical environment. It's not necessarily about medicines or procedures or diagnoses even. How do we prevent challenging behaviors? Teach communication. That's one. On the first slide there, the Office of Developmental Primary Care has a guide called Everyone Communicates on our website, and it guides you through how to get a communication evaluation, how to know whether you're getting a good one, and how to exercise your rights to communication access through the various systems. So if people don't have a fluent, functional form of communication, then that's very frustrating, and it's going to lead to a lot of problems. It's going to make it very difficult to diagnose medical problems and behavioral symptoms. So working on their communication and giving them better ways to communicate is critically important to managing behavior. Person-centered planning, giving people choice and control over their own lives. When people have choice and control over their own lives, they're happier and function better. That's the reality. Healthy lifestyle. Right now during COVID, a lot of us have found it difficult to get exercise, difficult to get sunlight, difficult to get uh, relationships and other good food, and focusing on the basics: sleep, food, exercise, healthy lifestyle is critically important. If we don't get some of those basic needs met, we're all going to get cranky. Consider the health, social, and physical environment. Plan transitions carefully. So all transitions are made up of the people involved, the place involved, and the activities involved. Try not, when you're doing any kind of transition, and we've all had a lot of transitions lately. We're not going to school like we normally would. We're not going to work like we normally would. We're not hanging out with family and friends like we normally would. So we've had a lot of transitions in our lives. And when we're trying to do transitions carefully, we need to think about the person, the place, and the activity, and try not to change more than one of those things at once. So if you're in transition or trying to plan a smooth transition, try to do a familiar activity in a familiar place with a new person, or a new activity with a familiar person in a familiar place, or have a familiar person, uh, or only switch up one of those things at a time, and then gradually build it up so that things aren't so abrupt. In our community, unfortunately, the risks of abuse, both physical abuse and sexual abuse, is astronomically high, and we always need, if somebody has a change in behavior or function, that always has to be something that we consider. Remember that most abusers are not strangers. They're family members. They're the people you trust. Most people who engage in abuse have groomed their uh, victims, and um, often have are providing them with something that they need: friendship, food, a place to go, something, uh, often housing, things that they need. Um, so it's critically important that, to prevent abuse, we avoid compliance training. So again, when people have challenging behaviors, we often are emphasizing to people, listening to authority and obeying orders, and obeying instructions. But it's really important that we teach and respect people's boundaries, that we teach people to that we give people a way to communicate that they're being mistreated, even if they have very limited communication, and that when people set boundaries, they don't want to kiss or hug somebody, they don't want to go with somebody, or something like that, that we respect that. um, uh, that we need to, and we need to uh, enforce in ourselves appropriate boundaries. So if you're in a professional relationship with someone you're supporting, um, uh, don't call them honey. Don't refer to them as your girlfriend or boyfriend. Sometimes those boundary issues, it's very important to teach people what appropriate boundaries are and not to cross them, so that they'll recognize when something is not right, because abuse is so common. So make sure that we're not overemphasizing compliance. If somebody really doesn't want to do something, then there may be a good reason. So when we talk about challenging behaviors, usually people, and they know I'm a doctor, the first place they go is medication. I've given this whole talk and haven't talked about medications at all. Um, I Medications usually are not the answer. There is no pill for challenging behavior. Um, there are pills that can sort of generally sedate people and maybe make things better, and there might be a place for that. Some chemical restraint if somebody's really in a dangerous situation temporarily while you're sorting things out. But in general, there isn't a pill for challenging behavior. And so you need to make a more specific diagnosis. There are pills for more specific things, like someone who's anxious or depressed, or there may be medications that might help, or maybe the side effects of their medicines are part of the problem. But I will just say these sort of general principles about medication. The goal of medication should always be to increase the quality of life and function, not to make people behave normally, whatever that means. The goal should be developmentally appropriate. You should make a diagnosis before you start prescribing, and challenging behavior is not a diagnosis. explore improving participation, inclusion, and the environment before or while you're considering medication. Make sure you're treating the caregivers, if the caregivers and their distress is part of the issue. In people with intellectual disabilities without mental illnesses, placebo is more effective than psychotropic medications like common ones, Abilify and Risperidone, and medications like that. Psychotropics frequently are used as chemical restraint, and for short-term chemical restraint, like to perform a medical procedure or something like that, that might be appropriate, but not for long-term use. So how do you monitor the effects of therapy if you do a medication trial? Research past medications and what happened. A lot of times if people have are key family members, like a parent has passed away or is no longer able to give a history, or people change medical providers, we may lose some of their medical history, and we may have tried medications and they may have had good or bad effects in the past, and lose that information. It's important not just to keep track of what's helped the person, but also what hasn't helped, so we don't keep trying the same thing over and over again by accident. If you're going to do a medication trial, realize that we're experimenting. Every person's unique, and we don't know a lot about medication in this population. So make sure that you define objective measures and a clear timeline and milestones for what you're trying to achieve. What is this medicine trying to do? A lot of times people get put on a medicine, and people sort of they just get put on it. Everybody's afraid to stop it. They don't really know why they were on it. They don't know if it's helped or not. Sometimes I inherit people who have been on medicines for years, and nobody can really tell me what the diagnosis is, or what happened before, or any of the history around it. And I might try very gently, gradually, carefully to slowly wean them off of it, to see if they still need it, or if they needed it in the first place. Sometimes when I do that, I say, oh, that was why they were on it. And, yes, they're much better on it, and I put them right back on. But a lot of times we can get rid of medicines that may be causing more side effects than they're worth. So when you're starting a medicine, make sure that you're defining those measures and timelines and milestones, so that we get people off of things that aren't helping them. I often talk about if we're giving medicine for behavioral symptoms, which again is not the main or primary solution, then I uh, want to make sure that we know what we're treating and why, and have really clear goals, and get them off of things that aren't working. And I look for a wow factor. So if people come back to me and I say, is this helping? And they're like, well, maybe, I'm not sure, then maybe it's made a difference. If they're sort of vague about it, then it's probably not worth it. It's probably not worth the side effects. The medicines that work really work. They're like, oh, this is night and day. This is this really helped. You might try an AB trial, which means put them on the drug, take them off the drug, put them on the drug, take them off the drug, because sometimes if we didn't really know why somebody was having the behavior, we put them on a medicine, and they get better, that may be because something else in their life changed, and it wasn't really because of the drug, even if they did get better. So taking them off again, we should keep trying to take people off of things carefully, slowly, gently, at a good time, to make sure that we don't continue medicines that may have long-term side effects, if they're not benefiting the person. When doing a medication trial, make sure the entire team is on board: day program, school, caregivers, case coordinators, primary care. Make sure everybody is on the same page in terms of looking for side effects, looking for beneficial effects, take data across settings, and keep good notes, again, on both what worked and what didn't work, so you don't repeat the same trials. So summary: Illness presents as a change in behavior or function. Don't get distracted by trying to stop the behavior so that you forget to ask why. Don't forget to ask the person, even if their communication skills are limited. Interpret behavior neurologically and developmentally. Improve quality of life, improves behavior. Take care of caregivers, and don't panic. Challenging behavior gets better. I'm gonna open it. I'm gonna stop screen sharing now. Let me, if you want to contact me, here's our website. We have many more resources that may be of use to you on our website, including tracking forms for various symptoms and more talks, more information on sensory information, um, lots of different materials on our website, and here's how you can contact. Let me stop screen sharing. Hi.
Hi, thank you so much. Um, I loved how you brought up that challenging behavior is a caregiver complaint, um, because it's such an important shift in how we kind of think about what's actually going on. And there's a John Lennon quote that I really like, and it's when you're drowning, you don't say, I would be incredibly pleased if someone would have the foresight to notice me drowning and come and help me. You just scream. Um, and so, you know, it's it's very empowering to get all of this background information. And something I've seen a lot of parents and self advocates talk about is that, um, they may be experiencing pain or there is a sudden shift in behavior, and they'll, try to seek medical help and are kind of told, well, it's just the autism. And so that's obviously very frustrating to people and, isn't actually attending to the needs of the person. So I think just hearing all of this will be really helpful and supportive of people. And I've heard you mention the unconscious bias that goes along with the autism label. Um, so again, separating the label itself from the needs, including, medical and emotional and physical, um, is really great. Um, okay, so I know that we had at least one question. So I will ask that. And if anyone else has questions right now, please post them. We would love to hear from you. Again, try to respect a patient's anonymity and um, we'll do the best that we can. One question we did have was actually related to the patient biting their thumb. And did you find out the cause of why that was occurring?
Uh, no, it wasn't my patient. It was just it's a story of somebody. So I don't know the family, but it had
Okay.
escalated to the point where they had called Child Protective Services on the caregiver, who is a very good parent and doing their best and trying to manage a very difficult situation. Um, and uh, and no,
Mm.
no, that there there wasn't, but he did. I mean, when there was no thumb, he no longer sucked his thumb. Then he developed a new symptom of very aggressive regurgitation of that was causing serious esophagitis. So some of these problems can be really difficult, and they're
Yeah.
we may not have good or easy answers, but don't I would just say don't give up, because a lot of times I can have patients who, the families are so overwhelmed, and we don't have answers, and having that humility, we don't have answers, but just engaging in that process of keep thinking about it. And just because you don't come up with the answer the first time or the second time or the first 3 months that you saw them, um, uh, I would say 98% of the time, eventually we hit on it. Sometimes sometimes, something will, once people's awareness is raised about what the possibilities might be, what they're looking for, they're much more likely to come up with theories that then we can test, to see what's going on. And if you don't know, ask other people, to get more ideas about what could be going on, because otherwise, we say in general in medicine, if you don't think of it as a possibility, you're not going to make the diagnosis. If it's not on your differential diagnosis, you're not going to come up with it. So having as broad a list of possibilities as possible, and I tried to give you lots of stories and lots of possibilities in this talk, but I'm always, when we have a situation where we're really not sure what's going on, someone who has a lot of experience, who's seen a lot of people with disabilities, who's worked through a lot of these problems, might be able to give you some ideas that you hadn't thought of before. So I'm happy to talk through with people. I'm not, I can't give you direct medical advice. I can't be your doctor, but I can listen to what you're experiencing and try to give you ideas of what could be going on that then you can go and test with labs or different experiments to see if they might make a difference.
Yeah. Um, okay. I would love to circle back to something that you and others have discussed before, regarding communication being a two-way street.
Mhm.
Um, and again, it's one of those reframing things where, the responsibility is on not just the person with the communication disability, but also, anyone who supports them. Um, we actually have Rudy Riggin, who's doing a webinar with us in a couple weeks. And so she was discussing strategies to help caregivers and practitioners become more skilled at communicating with people with communication disabilities. So I wondered, as a physician, what advice do you have for clinicians who are, writing in the charts and describing patients for, other clinicians to read? How should they, how should or should not describe people with unreliable or no speech, or, these so-called challenging behaviors, um, in a way that would enable everyone to kind of continue this deep dive of, what's actually going on?
That's a really good question. When I talk to my students, when I teach my students, one of the things that I teach them is that it's critically, because illness presents as a change in behavior or function. We have to know what people's baseline is. We need to know not just what's normal for the general population, but what's normal for this person. And so whenever they meet a new patient, whenever they're writing a note, they need to create at least a very basic profile of who that person is. How do they communicate best? What is their neuromotor function? That means like their mobility. Can they walk? Can they run? Can they climb? Can they use their hands? Can they manipulate fine things? What's their seizure, their mental health and behavior, and their sensory profiles. So you can make big obvious mistakes if you don't get that baseline. Stories, examples of stories. I had a patient who caregiver insisted they couldn't give me a history, said, I'm your guardian, I do everything for them, etc. Patient was sitting on my exam table, they were sitting where the patient normally sits, and I started going through my normal, what's this person's baseline, and they said, oh, well, she, cognitively, oh, she got through school, and she's also deaf. I'm like, oh, does she read lips? Oh yeah, she reads lips fine. And so then, um, and it's like, oh, okay. So I was told that this person couldn't communicate with me at all, but obviously they could. And so then I had them come off the exam table, sit where they could actually see my lips, and we could conduct the rest of the exam directly with her, no problem. Um, other, um, so I always tell that you should never put patient non-communicative or patient. Uh, it's okay to put patient as non-speaking or patient as non-verbal, but it should always be paired with and
Yeah.
communicates best by facial expressions, or communicates best by hand leading, or uses an augmentative communication device, or points on a letter board, or types, or how that you should always figure out how somebody communicates best
Right.
and document that. And if you're documenting a deficit, also document the strength along with it. um, in the disability community, there's a term, it's called a chartoma, which is when you get something in your chart that triggers people's unconscious biases about who you are. Like, this patient is they've gotten some, maybe you were in pain and flailed and hit a nurse once or something in the emergency room when you were having a behavioral crisis, and now every time somebody opens up your chart, it says, aggressive patient, call the cops to come, every time you go, even though that was a very specific situation. That doesn't, and but now it's in your chart and it's very hard to get rid of it. And you can't tell somebody to remove something if it's not inaccurate from a medical record, but you can put a comment next to it. You can ask your doctors to be careful about what they say. So um, I some of the things that I'm very careful about, I don't put the term intellectual disability, especially. I don't put the term intellectual disability in people who have communication problems where I know they couldn't have been assessed
Right.
accurately. A lot of people come with that diagnosis, but I can see what is it based on, or if it's there and it needs to be commented on, I'll say intellectual disability, but it's unclear how this was determined, because they don't have the communication and the motor and the motor skills to do accurate assessments.
Mhm.
Uh, so yes, and we should be very, very careful about how we document these things in this chart. You can document your observations. um, you know, it may be true, patient, waved their hands wildly and, hit a nurse or something like that.
Right.
But you don't have to give them a label that means they're an aggressive person or a dangerous person in some way, just because this particular thing happened on this particular day.
Yes. Um, we do have another question, but I also wanted to, while you are talking about not labeling someone as aggressive, because I've also heard you talk about how not all behavior is communication, which you mentioned earlier.
Mhm.
Um, but so some behavior is not even purposeful. It's information, but it may just be movement. It could be fight or flight response. And could you just discuss that a little bit further? And I've also heard you give examples of how like neurotypical people, I mean, we have the same experiences at times. Would you just give us a couple of examples? Because I think it's really, again, is
Mm.
relating the two experiences are what help us to really understand better of what is going on.
Right. So we all have experiences where um, our the way our brains work is we get information that comes in through our environment. It's sensory information that may come in through our eyes or our ears or our touch, or our taste, and then our brain processes that information, and then it sends out signals to our body to do helpful or not helpful motor movements. And in people with neurodevelopmental disorders, autism, or other neurodevelopmental disorders, there are frequently scrambles in that whole system. So people may not be able to feel or see or hear, or they may feel or hear or see very acutely, maybe even better than neurotypical people do. How their brain interprets that sensory information that they're acquiring, um, their ability to process it. So when you think about it, something like pain in your body is it's a very complicated thing to get help for pain. So first you have to have a sensation in your body, you have to feel it, you have to understand whether it is that normal or is that a sign of an illness. And we all have pains. You might get a gas pain, you might get a little twinge here and there of all sorts of things. So we all get pains all the time, and yet we don't run to the emergency room every time we feel an uncomfortable sensation in our body. But a lot of people with neurodevelopmental disorders might have those sensations triggered by things like someone flipping on the lights, or by the sound of the refrigerator, or by being a kid shriek, or something that isn't actually a health problem, but they're getting that painful sensation in their body, and then having to decide, okay, is this the sign of a medical problem or not? Then if you've decided it is a medical problem, then you need to communicate that to somebody else who could be helpful and figure out who that might be. If you just sort of, sometimes people might be saying it, but nobody's hearing it. And or so there's having those scrambles in our bodies, in the bodies of people with neurodevelopmental conditions, are very individualized. They're very unique. We need to understand how individuals process the sensory information that they're getting, how their brains interpret it, and then how they're able to move in response to it. We all have experiences with these kinds of sensory and movement scrambles. For example, most of us have at some point someone startled us, and I, bop somebody by accident, or someone, we got a sensory thing that startled us, and we screamed all of a sudden, when there wasn't really a threat there, but our primitive lizard brain thought, I'm under threat, and we suddenly did something. We had a fight or flight. Most of us have gotten nervous and haven't been able to speak, and kind of froze and couldn't do what we needed to do at some point in our lives. So so we all have these kinds of sensory movement difficulties at different times in our lives, but people with neurodevelopmental disorders, and some people have them a lot more frequently, a lot more dramatically, and they can be a lot more challenging in terms of helping, in terms of causing functional problems for them throughout their lives. So, and can also be functional advantages. So some people who have really, 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 really good hearing and can distinguish tones and sounds in ways that I can't, might be a really good sound technician, or people who can see really fine differences in colors might be really good artists. And I mean, these sensory differences don't necessarily have to be deficits. They
Right.
can be advantages in the right, if they're in the right environment, if they're appreciated and recognized. But they can also create challenges in a world that's not designed for them.
Yeah, absolutely. Um, okay, we have one comment that said, it's important to look for medical professionals who understand disability and the issues surrounding it. Not all do. And then from our very own Dr. Liz Torres, she said, how are physicians helping spread this important knowledge to first responders like police, firefighters, or even the school system? And how can we help spread the word in the research world?
Ah, I was thinking about you, Dr. Torres, recently, thinking, I wonder if she could study not just the movements of people with disabilities, but the movements of their caregivers. I was actually, I have a research idea for you, that may or may not have any merit, but anyhow, um, uh, yes, we need to make we need to make everybody aware, and that's what the Office of Developmental Primary Care is designed to do. And we have a lot of resources on our website. We do a lot of trainings like this, but we need to spread the word, and we also need people with disabilities to have the opportunity to speak for themselves. So the more that people with disabilities can write about what's going on in their lives, and can get to the table where they can explain to professionals and police and first responders and doctors about what's going on in their lives, what's helpful to them, what isn't helpful to them. The more that we have community participatory research groups where people with disabilities participate in deciding what the research questions are, what the methods are, and how to interpret them. That's how we're going to make progress. People with disabilities need to be at the table. They need to get education so they can be at the table. So we need access to communication, access to education, and access to opportunity. And I think I've been emphasizing the things that we've lost in this COVID climate um, uh, uh, era, but there's also a lot of opportunities. Like there are a lot of very smart, interesting researchers who are bored because they can't do their research, who would be willing to talk to people with disabilities right now. And the online format can sometimes make things more accessible for some people with disabilities, or for and provide more access to inclusion opportunities. Like we, for example, struggle to be in our synagogue space, but online services work really well for us, and that's an inclusion opportunity we never had before. And so it doesn't have to all be bad. We can also look about how can we adjust to this new reality, and think about how do we make even more opportunities for people with disabilities to speak for themselves and to set the agendas, and that's how we're going to get better.
Yeah. I'm so glad you said that. We actually have two researchers that we're interviewing soon, doctors Christina Nicolitis and Dora Raymaker, and the focus is going to be on exactly what you said is, how do we better include autistic and disabled people in research as participants, as co-researchers, and making sure that we're studying things that are uh, important to them and, things that they feel need addressing. So I'm really grateful for you being out on the front lines. You're an amazing doctor, and I'm so thankful that you came here today to present for us.
Thank you so much, and thanks for this opportunity. It's been wonderful, and I just appreciate everything you're doing. I'm so excited about the rest of your series. You've chosen some unbelievable people who I've worked with for years and greatly admire. So you'll have a lot to learn from them.
That's wonderful. And we'll be sure,
Thanks.
we did post your website in the chat. We'll make sure that we also put that in the video description. And as Dr. Kripke said, if anyone would like to reach out to her, which is so generous and we really appreciate that, please feel free. And thanks so much for joining us today.
Thank you so much.
Thank you.
Appreciate it.